Welcome, everybody. My name is Kerem Topuz. I am the Marketing Director of Memorial Hospitals Group. We are a chain hospital chain in Turkey with 11 hospitals, one of the leading hospital groups of Turkey, which has been serving patients since year 2000. And I would like to welcome you to the second collaboration between Cedars Sinai and Memorial. Today, we are going to be discussing advancements in spine surgery. Our first collaboration was on advanced endoscopy about 2 months ago. And this is a series of events, hopefully, that we plan to continue throughout the fall season with different topics. So I encourage everybody to follow us and join our sessions in the future. Like I've said before, today we are going to be discussing advancements in spine surgery, and with us we have Professor Dr. Emre Acaroglu from Memorial Ankara Hospital. He is the head of our spine center there, and also Dr. Tiffany Perry from Cedars Sinai. She's also in the neurosurgery department in Cedars Sinai. And I would like to also introduce our panelists. In addition to our panelists, we have Dr. Takman from Cedars Sinai and Dr. Kahraman, Professor Dr. Serdar Kahraman from Turkey. And together we are going to be discussing a few cases in spine surgery, and we are going to be discussing the advancements. Throughout these sessions, we will have time for Q&A. Hopefully the whole session will be done in 1 hour. Feel free to ask your questions through the chat, and we will try to help you as much as possible. At this time, I would like to give the floor to Dr. Acaroglu for the first case.
Hello and welcome from my side as well. Now, I will be showing you an adult spinal deformity case. This is pretty much a standard case, one of the cases that I fairly frequently do see. These are my disclosures. So this is a 75-year-old woman. She came to me with back pain radiating to both legs for the last 10 years. So in the last year or so, she was reduced to household ambulation for about 10 to 20 meters. So she cannot, it is impossible for her to get out of her house. Can stand upright for less than 5 minutes. So basically, she is very, very disabled. And then it appears that she doesn't have any major comorbidities. Let me see, sorry. Her neurology is normal. She complains of vague sensory loss, especially when she stands up. But she states that her visual analog scale for pain, back pain is 10. Visual analog scale for leg pain is 2 when she's sitting, and again 10 when she's standing. Her ODI is 82. 82, this is a scale out of 100, so we can say that she's very, very disabled. And then her SRS-22 score is 2.59. Again, the normal here, if you are not familiar with SRS-22, is 5. So 5 to 2.59 out of 5 means that she is very concerned about her deformity as well. These are her x-rays. As you can see, she has deformity on both planes, the AP plane and the sagittal plane. Her lumbar curve is 30 degrees, her thoracic curve is 33 degrees, and her upper thoracic curve is only 3 degrees. On the coronal plane, as you can see, she's fairly balanced, whereas on the sagittal plane, she has a lumbar lordosis of 19 degrees, thoracic kyphosis of 14 degrees. This is from T5 to T12. Her SVA is 27 centimeters. Again, let me remind you that the normal here is pretty much 0 to 5 centimeters, maybe. Her pelvic incidence is 65 degrees. Her sacral slope is 29 degrees, and her pelvic tilt is 35 degrees. The importance of pelvic incidence here is that with such a pelvic incidence, we would have expected her to have a lumbar lordosis of around the pelvic incidence, so like plus and minus 10 degrees. So from 55 degrees to maybe 70 degrees of lumbar lordosis will be normal to her. But as you can see, it is very much reduced to 19 degrees, and this is potentially one of the reasons why she cannot stand up. As the clinical presentation suggests, she has in her lumbar spine spinal stenosis at various levels, both as foraminal or lateral recess stenosis, as well as you can see, she has at 3-4 and 2-3 and 3-4 a fairly serious component of central canal stenosis as well. So in summary, this is a 75-year-old woman with spinal stenosis and degenerative deformity, fairly balanced in coronal plane, whereas severe sagittal plane imbalance. Her VAS for pain on both the back and the legs is 10 out of 10. ODI is 82, SRS-22 is 2.59. Sorry, this is a type. There's a typo here. No major neurological loss and no major comorbidities. So the discussion here is that we see these patients, although like maybe in some countries, they do not come to a doctor's office after they are disabled that much. She may have presented earlier, but the question here is that, it is clear that she needs to have some sort of treatment, but the discussion will be based on what that treatment may be. Is it conservative treatment? Should we consider her as being too old for a major surgery and give her some pain medications, pain interventions, maybe algological interventions, or physical therapy, muscle strengthening exercises? It appears that she may benefit from some strengthening of her lumbar and thoracic extensor muscles and her social support. Or should we go to surgery? And if we go to surgery, should it be only decompression surgery, decompression of the stenotic segments, or decompression and instrumented fusion? If we do fusion, should it be only at the stenotic segments? I think I have summarized that her main deformity is actually in the lumbar spine. So should it be a lumbar decompression and instrumented fusion, or should we go from upper thoracic spine to the sacrum? And by definition, when we go to sacrum for such a long with such a long instrumentation, it means that we need to go to pelvis. So this is again a fairly common case in my practice, and I would like to hear the panelists' opinion on how to approach this patient.
So Emre,
Yes,
I'll start with a question. What patients do you decide to get bone density studies on? Was this a patient that you got, CT pre-op, and you also got bone density?
This is not a routine in our practice because, two things. One, if you do a DEXA, then as she's very stenotic, the DEXA may mislead you. She will seem to be less osteoporotic than she actually is. And then QCTs are not very common in Turkey. And then two, I usually do not see any benefit to it because I tend to think that, in my personal opinion, it doesn't change my approach to the patient very much. Like, I do not refuse operating on patients just because they are osteoporotic.
Sure, but would you consider adjuncts such as medications like Tymlos or teriparatide, or would you consider some sort of adjunct to try to treat osteoporosis or a T-score of -2.5 or greater?
Yeah, obviously, yes. Teriparatide would be the choice then, because it is potentially the only drug that can have I would say a substantial improvement in the bone mineral density. But then, this is something that we're discussing a case from Turkey now, and it was not routine to prescribe teriparatide for patients in Turkey. It's very expensive here, and it's not usually covered by the social security system.
And the other question is that should we know the dynamic graphies of the spine in terms of to understand the rigidity of the deformity in this case?
This is pretty much what I have. I usually do not have dynamic studies as well. I know that many people do them, and I know that mostly neurosurgeons like to have dynamic studies. But I actually doubt. If you compare, let me go back.
Emre, I think you do have a dynamic study. You've got her standing X-rays, and you've got her supine MRI,
right. So
which
this is
beautiful.
This is what I was going to say. Yeah, this is what I was going to say. So this is, you see, this is the MRI, pretty much synchronous with the X-ray. The X-ray looks like this, and the MRI looks like this. So we can say that she's flexible, but I don't do flexion extension X-rays, if this is specifically what you're asking for.
Okay.
How about anterior column support? Things like, A lifts or a combination O lift, D lifts, T lifts especially at the foundation, at the base of the construct. I definitely in deformity surgeries, especially in postmenopausal women, but essentially any deformity, restoring the anterior column, allowing surface area to be able to ensure that the foundation of the construct, most importantly at the lumbosacral junction, is going to be able to have arthrodesis or a solid arthrodesis form. I would have considered, anterior column support in her. The other concern that I had in her, it looked like on her AP scoliosis X-ray that she did have an L1 compression fracture of the superior end plate. So definitely in her specifically, one of the concerns I have is bone density arthrodesis.
Mm-hmm. Yeah, I think this is something that we need to discuss. So this may be the third option. So would you do posterior surgery along with anterior surgery, or only posterior surgery? The reason I'm asking this is that like the discussion here becomes, if we can restore her sagittal balance, do we really need to do any O lifts or A lifts? Well, except the lumbosacral junction. For the lumbosacral junction, obviously we need to do because of the risk of pseudoarthrosis, though, not necessarily just so as to correct the deformity before they put the posterior instrumentation. So again, like this is something that we may want to discuss as well.
Hi, yeah. So this is Alex Tuchman. So I had one more thing to bring up with this case, especially because we're kind of piggybacking on that point. We're concerned with a multi-level decompression, getting fusion, especially through the thoracolumbar junction. Are you typically in cases like this, if you're going to correct this deformity to the upper thoracic spine, which I think if you're going to tackle this, you probably do need to go to the upper thoracic spine, then are you using 3-rod or 4-rod constructs? What levels are you spanning in those constructs? And how are you incorporating pelvic fixation into that? I think is always a good thing to think about in these cases as well.
Yeah, this is a very good question. I think, yeah, we at this time, like when I treated this woman, we were not using them, but that was about 10 years ago, and nobody was actually discussing about like using 4-rod or 6-rod constructs at this time. But then eventually, first, we saw that if we do any tricolumn osteotomy, the pseudoarthrosis rate of tricolumn osteotomies was more than 60%. I think, in my opinion, it's very close to 100% because they do not heal from the front, they do not heal from the back as well. So then we switched to using additional 2 rods only at the site of osteotomy. That was like until maybe 5 years ago or so. But for the last 5 years, we have been using routinely 4-rod constructs. If we do use 4-rod constructs, then it becomes from it. Then the other 2, the supplemental 2 rods come from the lower thoracic spine to the sacrum, and then the real rods come down from the upper thoracic to the iliac fixation, and I usually connect these two sets of rods with dominoes on each side, like 4 dominoes at least, maybe 6 dominoes. But then I do not use like if you think I do not like use lateral screws and well forward going screws. So like the two rods, the two supplemental rods are actually only supplemental rods. They're not connected to pedicle screws except for the iliac screws or the S1 screws. So they're just connected to the other rods. And I personally, I never use 6 rod.
And then I have another question. In orthopedic spine surgery, routinely you do not use the EMG, electromyography investigation. So in this case, we almost have a normal neurology. That means even the stenotic segments, we don't have any neurological signs. How do you decide about the decompression level? Only rely on the MRI images?
Correct. Yeah, I mean,
the main problem is the sagittal imbalance in an axial pain, you know.
Correct. Well, she has both basically, because when she stands, she has neuropathic pain in both legs as well. And now obviously, since she can walk only 10 or 20 meters, this should be considered as being neurological, neurogenic co-location. For EMG, we do not use it because, as far as I know, there are several studies saying that they're not very specific. Like if they tell you that the radiculopathy is at these levels, it is clear that she would have radiculopathy at those levels, but that it does not exclude the other levels. So it's like it is sensitive, but it's not necessarily specific.
Yeah.
So basically, my decision, at least for me, my decision for decompression is based on the MRI images.
Okay.
Yeah, I think the other point is if you're going to correct through this, right, and you have some even moderate stenosis, you have to be concerned. Are you using, in terms of, you said you don't use EMG nerve conduction studies, but you do use intraoperative neural monitoring for these cases, of course, right? Yeah. So especially if you're going to get a major correction in the sagittal plane, you worry about worsening stenosis from that standpoint. The other point that I think you hinted at earlier on your previous slide is that sometimes, especially with flexible curves in older patients or even younger patients, just because they appear to have a sagittal deformity with bad stenosis, they may not, and you have to evaluate the patient very carefully in clinic and see why they're not standing up straight. If they're doing that to compensate for their neurogenic claudication, or if it is truly a deformity. And I think you hinted at that, saying, oh, maybe it would be an option to try a decompression first. This seems more like a true deformity, but that's always something to keep in the back of your mind, I think.
It is. I totally agree. So thank you for raising this point. But then I think the discussion here is about, like, if her sagittal plane, I would say sagittal plane alignment as is based on her stenosis, which may be because it corrects, it's fairly flexible. Would decompressing her correct her sagittal alignment? Usually our thinking goes in a way that the problems of these patients cannot be solved by decompressing them only. So even when you get rid of the decompression, then you would be actually sacrificing the posterior elements mostly, and then they have a mechanical failure at their back as well. So one option here, as Dr. Perry has stated, might be to do a posterior compression followed by anterior surgery, anterior instrumentation in this case. But would you rather do that?
So I think my thought was sort of like a 3-4 level ALIF, probably 3 levels, which would also help with the coronal alignment in the lumbar spine. The other nice thing about that is if it is a patient that you feel pretty comfortable in increasing the disc height with your ALIFs, it's nice because it can also open up the foramen if you're worried about the foraminal stenosis note on the MRI. Mm-hmm. And then locking her in from the back and obviously going up the thoracic spine with the deformity correction. But I would go anterior first and then posterior for locking in facet resection osteotomies of the upper lumbar, and then I think that potentially, and I think this is really where one of my big questions comes in. Where do you stop when you do that? So I think that she still clearly would have some sense of mobility in the thoracic spine. She's not rigid there, clearly, because you realigned her readily with just with posterior screws, right? You gave her a little thoracic kyphosis on her positive x-ray. So one of the questions is where do you stop? Where do you allow the patient to, when you restore lumbar lordosis to her, she's hopefully going to have some compensation with their mid-thoracic, upper thoracic kyphosis. So where is that stopping point? And I think that's a big question that I have.
Yeah, it's a big question that everybody has, basically. So yeah, some people go to T2 in all their cases, saying that, okay, so we have to cover all the entire thoracic spine and the entire lumbar spine. You may go to T4, you may go to T6, you may potentially just stop at the lower thoracic spine. And the rationale of stopping at the lower thoracic spine would be, if you notice that she has actually a 14 degrees thoracic kyphosis. So she's basically trying to compensate from her thoracic spine as well, so as to be able to stand erect. So this is usually a very good sign. But then again, I think it's very, very unpredictable. So we usually go to T4 in these cases. It's just an arbitrary choice, I would say. And then literature does not suggest that you should go that way, this way, or that way. Now, the selection of the upper thoracic, the uppermost instrumental vertebra is very relevant. Because there is a discussion about whether it would actually affect or it would prevent any proximal junctional failure or proximal junctional kyphosis. But then we don't know whether you can eliminate it if you had you stopped at T2, T4, T8, T10, wherever it is. Again, the literature suggests that if you can restore their sagittal balance, then the likelihood of having proximal junctional failure or kyphosis decreases. But then again, yeah, like this is a case from 10 years ago. Like, had I done her now, I would potentially consider stopping at T10 and just try to get a very good correction at the lumbar spine, especially in the sagittal plane, not necessarily in the coronal plane. Because now, again, this is connected to the discussion about whether we should be correcting the lumbar scoliosis that much, because her thoracic spine may be flexible in the sagittal plane, which appears to be so, but not necessarily in the coronal plane. So then, if you correct their lumbar scoliosis very much, we can potentially give her a coronal imbalance as well. So like it is something like either you correct the lumbar scoliosis totally, then you have to correct the thoracic scoliosis totally as well, then you have to go to the upper thoracic spine. Or if you stop at the lower thoracic area, you will not be correcting the thoracic spine. It's not likely to correct by itself. Then you should not be correcting the lumbar scoliosis that much as well. Does it make sense? Okay, so should I go forward with my solution?
Yeah,
so
sure.
I did. Let me see. Okay, here we go. So again, this is a summary. Neurology normal, coronal plane. So I did surgery, as you may have guessed. I decompressed all lumbar stenotic segments. I did chevron osteotomies. These are posterior column osteotomies, or like if people who are watching this are familiar with the Schwab classification of these posterior column osteotomies, I would call them like maybe type 2 osteotomies. So they're not only osteotomies of the medial facet, but they involve the excision of both facets. So the medial facet and lateral facet bilaterally was taken out. And then I instrumented her from upper thoracic spine to ilium. This is her immediate postoperative X-ray. I know that this doesn't look very good, but then still. So as you can see, I stopped at T6. Now, one thing to discuss here that at that time I was using the S2 to ilium screws, the so-called Quebrech technique. As you can see, when we woke her up and had her first erect X-ray, this is the first erect X-ray, we saw that that iliac screw on the left was actually decapitated. As you can see, there's a disconnect between the head of the screw, which is here, and the shaft of the screw. Then I encountered this complication in several other patients as well, and this complication arises because now you have to give the screw a very acute head shaft angulation in order to put the rod in order to be able to insert the rod again. So this is her post, this is her at 6 months. So lumbar lordosis is now 42 degrees, thoracic kyphosis 33 degrees. SVA has been reduced from 27 centimeters to 6 centimeters. Now the pelvic incidence seems to have been changed, but I think this is just because of the X-ray. So she has a pelvic incidence of around 74 degrees. One of the important things here is that her pelvic tilt is still 36 degrees, so we have not been able to bring her pelvic tilt to under 26, under 20 degrees. So although she can stand up fairly well, as you can see on the lateral X-ray, she is still compensating. And if you look at her hip joints, you can recognize that they're fairly extended. So she's still trying to invert her pelvis so as to be able to stand upright like this. And then this is her at 2 years. We had to offer her another operation for the failed iliac screw at 6 months, at the end of 6 months. And in the end, this is the end point. So she has a lumbar lordosis of 46 degrees, thoracic kyphosis of 4 degrees, SVA of 94 millimeters, and still the pelvic tilt is 36 degrees. The story that I would like to discuss further is that this is at 2 years. She's still a household ambulator. Her walking improved to 100 meters. Her standing improved to 30 minutes. Her pain has pretty much gone. But then you see her ODI is still 66. There's an improvement of 16 points, but it is nowhere near normal. Normal is probably potentially under 25. And then the SRS-22 has actually deteriorated. Although it's a very, very minor deterioration, at least we can say that it has not improved. So now, why does this happen? This is something very frustrating, and this is something that we see in most of our adult deformity patients. So we were effective in decreasing the SVA. We were ineffective in correcting the pelvic tilt, but then she doesn't seem to be very much less disabled at this point. She can potentially walk further than before, but her ODI is not somewhere that we would like it to be. Any ideas? I'm not asking this because I know the answer. I'm just asking this, just raising this problem, and in my practice, it has been a fairly common problem. So when you look at her X-rays look very, very good, whereas and her pain has gone away, but she still feels that she is disabled.
So are you thinking that had you done, say, a front back, that her ODI would be less, would be better than, 60, what she is now? Is that what you're thinking?
I used to, in fact, I used to do front and backs, but then we encountered a fairly high rate of complications with the anterior surgery. And there's a paper from UCSF. It's not very recent. I think it's probably 15 years old now. And they were saying that of the patients that they had who had the front and back surgery, their rate of abdominal herniation and/or abdominal muscle denervation is maybe close to 50%, 40-something percent. And this then adds to their disability as well, because then their bellies sag on one side. And this is actually why I do not want to do a formal ALIF. I do appreciate that an XLIF or OLIF might have been a case, but this is not a case of pseudoarthrosis, because if she had pseudo, then she would have had pain, and her pain is actually much better. This is just something that we see with these adult deformity patients. There's a question in the chat, and the question is about, like, when we correct their lumbar lordosis, would it decrease their canal volume and then increase stenosis? If you do not do any decompressions or osteotomies, this is correct, because then there will be obviously some buckling or infolding of the ligamentum flavum, which may potentially increase the spinal stenosis. But this case was actually decompressed, so we did laminectomies on her in the lumbar stenotic segments. Then if you do decompression, it's not very likely that you will end up with increased spinal stenosis in these patients.
And regardless, they mentioned in the question, won't it lead to cord impingement? So the cord is not in the lumbar spine. This would be the canal. And so certainly you could get some stenosis potentially, but we aren't really worried about cord down at the lumbar spine.
So yeah, I think this is a very, frustrating case. And I think we all have these patients where the x-rays look great and, the CT scan looks fused and the patient's decompressed. And in this case, right, I think you achieved your goals of fusion and decompression, like you stated, with the VAS being, in terms of back pain and leg pain being improved. And so that, that's always one of the first things you kind of look at, is there some lumbosacral pseudoarthrosis that's kind of driving this issue? And I think it may be part of the reason why you redid the pelvic instrumentation off the bat. That seems like the right thing, but then still not quite happy. I wonder now, when you go back to your x-rays you measured, and it's hard for me to eyeball this, your LLPI mismatch seems to still be elevated. And so possibly, so she's balanced on her standing films, but is she using a lot of pelvic tilt to balance herself, right?
Right.
And what I've found is that a lot of times the x-rays can look very good in the standing position with their pelvic tilt, but then when they get up to go walk and actually do functional activities, they can't do anything with that amount of pelvic retroversion because they've already maxed out their hip joints. Right. And so it kind of falls into this kind of compensated sagittal plane deformity group. Now the fix is once you have this situation now is a 3-column osteotomy. And I think the other possibility for a case like this, which is a little more controversial, is the spinal shape correct, right? Like, is this the correct, you may have gotten enough correction, but is the spinal shape correct? Is this, is the apex of lordosis the correct apex of lordosis for this particular patient based on the Russell classifications, which I think is beyond the scope of this particular talk. But so, you know, it's hard, you know, and it's tough to say if that is really real. And I think we're going back and forth, you know, is it about just getting the patient balanced or the spinal shape and all these types of issues that need to play the role. But either way, the fix to this particular situation now that they're fused, they're decompressed, would be a 3-column osteotomy. And the question becomes, you know, her back pain better? Is her leg pain's better? She doesn't have any obvious, you know, absolute indication for a revision surgery. Is it really worth the significant risks associated with the 3-column osteotomy to fix that? And are you sure that after you do it, that she's going to be happy with that result? So these are tough cases.
So this I think I completely agree with these comments. So I think the issue here is that like again at that time we were not actually aware of the importance of the location of the apex of lumbar lordosis. Since she has a very high pelvic incidence, her apex of lumbar lordosis should be very, very low. Like at that time, when I was doing tri-column osteotomies in the lumbar spine, I tended to do them at L3. But now this particular woman would definitely have benefited from a tri-column osteotomy at L4, even L5, with such a high pelvic osteotomy. And at that time, we did not know how to do the L5 tri-column osteotomies as well. So this is an excellent comment, I think. And finally, I think the take-home message from this is that, like in these patients, you achieve some improvements, but not necessarily very substantial improvements. And then this becomes very important in explaining the situation to the patient and then consenting the patient as well, because you need to tell them, okay, so we can pretty much prevent your acute problems, but then you're not going to be back to your 18 years of age or 30 years of age. You will still be disabled this much or that much. I think this would be the take-home message from this case that I have presented. So thank you very much. I think we're already fairly over time with my case. So if you do not have any further comments, then we can proceed with the other cases.
Okay, Kate, you tell me when you've turned over the control to me. Okay. So Kate, is there a little delay here? It's not allowing me to advance.
You can try right now. Yeah.
There we go. Okay. So for mine, I'm going to talk, we're going to shift gears a little bit and talk about tumor case, hopefully followed by another case. Both of these are cervical spine, occipital cervical junction. First case is a 37-year-old female who presented with an unusual history. She was basically woken up on a sort of Sunday night, early Monday morning from a dead sleep. She had explosion at her right temple, onset of right facial numbness, feeling of blood rushing down the entire right side of her body. She had extreme pain on the entire right side of her body for about 10 minutes. So her husband, she's married, she's got 3 kids. Her husband thought that she might be having a stroke. She had no loss or a seizure, no loss of bowel or bladder. They thought less likely seizure. She was completely conscious the entire time. She did have a lot of nausea, some diarrhea. Her bilateral fingers and toes went numb. They were continuously tingling, and this persisted. She stated that the back of her head and neck felt very cold, like even to touch. When she would touch it, it felt very cold to her. And her right ear felt clogged. She reported prior to this that she had had some gait and balance issues for about 2 weeks. She's actually a CrossFit instructor and a volleyball coach. So she's very athletic, very active, and had started noticing some difficulty with balance over the past 2 weeks. So right after all of this happened, and this is, late Sunday night, early Monday morning, she went to an outside hospital and they did a head CT to rule out any sort of hemorrhagic stroke. The head CT was read as negative. Then they did an MRI brain to work up for stroke as well. Let's see. So her exam, she's full strength in her upper and lowers. She says sensations intact, so she can feel you to light touch, but she has a cold sensation in the back of her head. Cranial nerves appeared intact. Her face was symmetrical, tongue midline, uvula was midline. She had no drift. She was unable to tandem walk. And at the age of 37, that's unusual. And she was unable to walk on her heels or toes. And it was basically related to proprioception issues. So we'll start by going through her imaging. So here's her imaging. And are you guys able to see my cursor on the screen? Can you see it? Okay.
Yes,
great.
we are.
So on the left side, I have the non-contrasted sagittal MRI. Here's the contrasted sagittal MRI, and here's a contrasted axial slice through the occipital cervical junction. And so we can see, so you can see how potentially a head CT could be read as normal. However, when we actually did get her outside head CT and looked at it, you could actually see this lesion here at the skull base on the head CT. So basically in looking, she's got a mass that spans from her cervical medullary junction all the way down to about the top of the C3 lamina. Right here is C2 spinous process. There is very, very subtle enhancement that you can see here in the mass on the contrasted study. You can see here on the axial as well, few parts that very subtly enhance. We honestly were not certain, for sure what this would be, but clearly symptomatic. So I'll go to the next study. So here's the T2. So you can see the extent of the mass. And then I think this is a little bit more beautiful picture of trying to evaluate where the mass originates from. So it looks like here she's got some T2 signal here inside the actual cord. You can see right here, almost like it's going into the central part of the canal or coming out from the central canal. So here is the lesion right here. Here is normal cord. And so the real question in looking at this, and here's a great axial slice of it, is this an intradural extramedullary tumor, or is this an intradural intramedullary tumor with an exophytic component? Anybody want to make a comment on that thus far? Because that's a real question, and going into the surgery in preparation for it is what type of dissection you're really looking at here, and are we looking at potential for a gross total, or are we looking at potentially leaving residual tumor along the central portion of the cord where this likely originated from? Any thoughts on it?
If you look at the T2 MRI, and then we can see the slightly overlapping on the tumor, and it looks like intramedullary with the exophytic components.
Yeah, so I agree. That's what we were thinking we were probably dealing with, was the latter here.
Mm-hmm.
So for her surgery, we did a posterior suboccipital bone resection, and then a C1 to C3 laminectomy for a section of the intradural and intramedullary exophytic mass. And so this is just a scan showing sort of the bony resection that we did. I performed this with an ultrasonic drill. I used the ultrasonic drill to basically resect a small portion posteriorly and of the suboccipital bone, and then also for C1 and C2 laminectomy, and then top of C3. So her intra-op post-op course, so basically dissected tumor away from the cranial to caudal direction. We lastly dissected the intramedullary portion away using a fine tip ultrasonic aspirator of about 1.1 millimeters. We had complete stable neuromonitoring during the case, and we kept her in the ICU post-op to keep her mean arterial pressures around 75 to 80 to ensure that, and of course intraoperatively as well, we had an arterial line to keep the mean arterial pressures up. She had full strength, so motor-wise, a successful surgery, but she did have residual numbness in that right hand, and that's actually persisted. She's right hand dominant. That numbness has persisted, but nonetheless, in spite of that, she has returned to CrossFit and coaching volleyball, and still is a wonderful full-time mother of 3 children. And here is her post-op MRI. This is 2 years post-op, showing the cord here, obviously the difficult thing, and this is not a vastly enhancing mass, so also very difficult to potentially detect early recurrence, if any. We felt radiographically and intraoperatively a gross total resection, which we were pleased with. The cord obviously has spanned back to its original, what should be original diameter. For her, the biggest thing now is, of course, following for tumor recurrence. And here is her non-con and contrasted sagittal MRIs 2 years post-op. Any questions or thoughts on this case? Would anybody, I think one of the questions that I have is, in going into these tumor surgeries where you're doing, wider dissections, bigger resections of tumors, more bony work, anybody would consider, and she's on her pre-op MRI, she actually has had this degenerative disc at C3-4, and she has another one at 5-6. Does anybody consider instrumenting these early at the outset? I didn't, for a couple of reasons. One, I didn't think that she needed it. Neck pain, occipital, cervical pain, not an issue in this lady. She's highly active, very young, and hardware only skews and creates artifact in trying to follow them post-operatively for tumor recurrence. So I think you have to be very judicious in consideration of instrumenting in these types of cases. Any thoughts or questions on this one?
What was the tumor? What was the tumor?
Yeah.
So it's a grade 1 subependymoma.
Sorry, ependymoma, grade 1?
Who grade 1 subependymoma.
Oh, grade 1, okay. So the main consideration is about that this kind of the intradural tumors. Nowadays, we are using routinely the unilateral approach instead of the total laminectomy. And we have a very huge experience about that, and it could be possible to remove this kind of tumor with using the unilateral approach. Are you having any kind of experience for the intradural tumors?
For this, I have not. For this, I have not done a unilateral approach. So what are you guys doing?
Yeah, yes, you can choose the dominant side of the. It depends on your location of the tumors. In this case, you can choose the right or left side. It's no matter. But I hope that I can think that this could be removed with using the unilateral approach, only the unilateral laminectomy. So we can remove this kind of cervical or thoracic intradural tumors with approach only the unilateral approach. So the main
so just so I'm clear, so it's intradural, intramedullary, and the intramedullary component is exophytic from the midline, but your intended dural opening is completely lateralized.
I can show you some couple of examples about the cervical or thoracic intramedullary ependymomas with remote by using the unilateral approach is possible. It's a little bit technically dependent, but it will be. The main consideration is about that it is a biomechanical problems. If you have any malignant tumors, and then you may have a radiotherapy after the postoperative period, and then it could cause a kyphotic deformities in the cervical area. So that's why we are preferring to approach this kind of intradural tumors in terms of the developing of the deformity, iatrogenic deformity.
But yeah, I mean, so this may be similar to the minimal invasive technique of like decompressing, bilateral decompression from unilateral.
Yes,
approach.
which is coming from the.
You're tilting your microscope and then tilting the patient.
Actually, we do not have any tilting nowadays because we have a very large experience about that. And if you drill about the under spinous area, and then process, and then you can reach the other side, opposite side, very easy. This is something
that we use for lumbar decompressions.
Yes, now, sure. This is the unilateral approach for. Yes, this is the classical unilateral approach for bilateral decompression. But it will be used, or it can be used in this kind of intradural tumors.
But then
Yes.
I think this discussion is not related to the residual right arm numbness. So, I mean, although Dr. Perry has performed like complete laminectomies, like occiput C1 and C2, I assume, right?
Yeah.
Not C3.
Yeah.
So she does not have any residual deformity as far as like we can see.
She did not as a radiotherapy postoperatively.
But then, like, may I ask, Dr. Perry? Now, if you look, this is the preoperative MRI, and we can see that she's not very stenotic at that point in the lower cervical area, whereas in the ensuing years, she actually did develop some stenosis. Is this correct?
So no, I think that she's got the same disc bulge at 3, 4, and 5, 6 on her post-op MRI. I don't really see a significant difference.
This is probably not a real very mid-sagittal cut, but like the pericord CSF column seems to have been larger in the pre-op.
You mean ventral to the cord?
Yeah,
right
but
here?
now I'm talking about like 2, 3. This is 3, 4. Yeah, I'm talking about that level.
3, 4.
Yeah, no,
between the C5, C6.
This is
C5,
5, 6.
C6.
Yes, this is 5,
Yeah.
6. I mean, I don't think that is associated with the residual numbness as well, because I assume that it came immediately after surgery. So this is not something that.
No, her numbness was present from the outset. So she had that from the outset of her symptoms, from that, Sunday morning, Sunday late night, burst of all the symptoms. It never resolved before surgery, didn't resolve with steroids pre-op, and didn't resolve with surgery. And so, we had her work with PT and OT just as far as, regaining, a bit. She's able to write, she's able to play volleyball, she can do her CrossFit training, she can do everything that she needs to. It's just this right hand feels a little differently. I don't think it's related to 5, 6, the 5, 6 is because I think that she had it pre-op. And certainly if it were a disc herniation, I would expect something more than numbness. I would certainly expect something like, radicular pain associated with it. She has no pain. Could it be something like a carpal tunnel? Sure. We can always think about peripheral nerve things as well, and we don't want to ignore those things. But given the stability of that symptom, right now, I'm not planning to do anything about it. She's perfectly happy with her life, going on as is. I don't think that I would, I feel like my bony decompression was narrow, which is good. We never exposed the facets, preserve all of the attachments laterally. So I don't, thus far, I also do follow her with serial x-rays every year with flexion extension views, just taking a look at the dynamics of the cervical spine and occipital cervical junction. I'll tell you, I don't think I have the balls to probably try the intramedullary unilateral approach. I'm very concerned with sort of the dissection of that part that's right at the central canal, which is where subependymomas originate from, right? That area, I'll be honest with you, I think we would have probably left tumor.
No. I can show you many cases, but it is possible. Depends on your experience about the unilateral approach. The other question is that, what is your criteria about the neuromonitorization? During the surgery, you use the all of nothing, or you use the less than the 50% decreasing of the neuromonitoring levels?
Less than 50%, but I do watch for changes no matter what. We watch for changes regardless. So, but yeah, with her, and you can argue, I'm sorry, do what?
Sorry, when you stop the surgery during the neuromonitorization, what is your exact criteria?
Less than 50%, basically. And I would want to, I would definitely want to be mindful of any changes. we're in the process now of sort of developing a protocol for deformity surgery, specifically excluding cases like this, tumor surgery, intramedullary tumor surgery, where we have a checklist of everything that we do if neuromonitoring changes. And her, fortunately, we didn't have any changes intra-op, which, nothing that changed. And we routinely, would work on tumor for a little while. Obviously, the bulk of it, as my chairman used to call it, the low-hanging fruit, the stuff out, laterally and in the midline, that stuff's the low-hanging fruit. That's easy to get. The part where you're worried is once you're starting that exophytic portion of the tumor, right? And so every 15 minutes, 10-15 minutes, we would just stop, check a motor, make sure that everything was staying stable. So, and then the other important thing is, I think, keeping the mean arterials up during a surgery like this. This isn't a bloody surgery. It's not a bloody approach. It's not a bloody surgery. But the key thing is just making sure that the patient's tolerating anesthesia well, and we're keeping perfusion to the cord the whole time.
Okay.
Yeah.
So case 2 is an 85-year-old female who's ambidextrous. She was coming to my clinic for evaluation of a C3 lesion. She and her daughter stated that she started having a cough about a year ago. It had improved with antibiotics, but she had been on 4 courses of antibiotics. She was having night sweats. She was a very tiny, petite person, had about a 30-pound unintentional weight loss over the past year, endorsed neck pain, worse with motion or activity. Hearing the weight loss, hearing the night sweats, obviously worried about, potential for metastatic cancer. Also, other infectious sort of pathologies do come to mind for her. She had 2 non-diagnostic bronchoscopies for a little lesion that they had found in the right middle lobe. She had no weakness on my exam, but she reported constitutional weakness. So her exam actually was pretty unremarkable. You can see here I have cervical range of motion up as well. She also, if a neurosurgeon is palpating supraclavicular lymph nodes, and they're obviously quite large, so for me to be able to feel that on my exam was quite impressive. So here's her imaging, and I'll just try to briefly cut through this. So you can see her kyphotic deformity spanning from C2 down here to the subaxial spine. Obviously an absent C3 vertebral body here. Here's the posterior elements of C3. Looking here at, I think most impressively, is the prevertebral edema right in here in front of C2 and C3. So this is obviously very concerning, but you can see that she actually does have a patent airway here. So here's her CAT scan showing basically a completely lytic process involving the C3 vertebral body. You can see the spacing in between C3 and C4 spinous processes, which is abnormal, basically related to the kyphotic deformity here. So then here's her MRI. Here, most impressively on the T2, you can see this prevertebral process and the prevertebral fascia just below that in front of the C2 vertebral body. Here's the C3 vertebral body here, disc space of 2-3, disc space of 3-4. And then here on the contrast enhanced study, very, very impressive amount of enhancement here. And then, of course, also impressive is the amount of cord compression. You can see the caliber of the cord here compared to at the C3 level. And just of note, you can see that she also has some degenerative changes in the subaxial spine otherwise, but obviously the primary issue at hand is here. So here was her PET. So you can see here in the right middle lobe of the lung, she's got this uptake here. She's got some supraclavicular lymph nodes here. Also on the right, concerning, and then of course the significant uptake here at the C2 and C3 vertebral bodies. So on her PET, they were concerned for lung cancer primary. They did a final bronchoscopy biopsy done, a third one right before surgery. They did some pathology that didn't really return any results and cultures, and they found out the day before her surgery that her AFB was positive. I did send her pre-op for a swallow study because I couldn't believe that she could swallow normally, but she did. There was no blockage, but they definitely could see that there was a significant large destructive lesion at C2-3. So for her surgical intervention, we decided to do a front-back approach. We decided to restore the anterior column and perform our decompression from the anterior part and then lock her in from the back. So we placed her first supine for an anterior C3 corpectomy, decompression of the cord, plated her from C2 to C4. Then we flipped her over for posterior C2 to C5 instrumentation with no decompression. We were comfortable with the decompression from the front. And reconstruction of the anterior column, and obviously I had to maintain TB precautions through the whole case. So here is her post-op imaging. Here is the cage which we placed in lordosis here from C2 to C4. The plate spanning with screws in at C2, screws in at C4, and then our posterior instrumentation spanning from C2 to C5. So here is her pre-op, and then here's her post-op x-ray. Any thoughts or questions on the case, or would anybody have done this totally from the back and decompressed? Would anybody have done it only from the front without posterior? What are thoughts?
No. I think no. The one discussion here, just very briefly, is that we see a lot of these. We used to see a lot of TB cases. Now they're coming down, but then still. Now, for this case, if she had neurology, acute neurology at the time of presentation, would you have considered traction? Because like if this, especially this location and TB is very amenable to be treated by traction. I'm not talking about a definitive treatment, but then just to decrease your risks during surgery, and they may actually get neurologically better if you just put them under.
So had
traction.
she, I think your question,
halo traction.
So your question is, if she had come in with neurological deficits, would I have placed her in traction pre-op before surgery? So
yeah,
no,
for some period of time.
Yeah, I use traction for mostly like trauma, jump facets, things like that. But if somebody has a neurological deficit, I'm taking them to surgery, because the other thing I would worry about in the traction in her, I think that on her MRI with that amount of cord compression that she has, I absolutely would not have wanted to. This is not bone in here. This is all compressive, infectious stuff. I would not feel comfortable placing her in traction and placing her in extension, because technically the extension's actually going to narrow her canal even more. This C3 spinous process and lamina is going to come ventral, right? I wouldn't feel comfortable with that. Ultimately, if she had a neurological deficit, we're going to surgery that day or the next day, right? I wouldn't feel comfortable placing her in traction with that.
Okay.
So I totally agree with the surgery. This is a very good option. But the technical detail is that the anterior approach just between the mandibula could create some difficulties in terms of surgery. So in this case, you achieve that, and sometimes you need to go for mandibulotomy. Depends on the anatomy of the mandibula. So that's why I want to underline it. Okay.
Yeah, and we were also very fortunate that she was a very small person as well. I think that helps. I think having a large neck to dig through would have also made this technically a lot more challenging.
Okay.
Yes. Yeah. Thank you very much. I mean, I think this was an interesting case. So I think it was good to see this case as well. Thank you very much for presenting it. Okay. So, Mr. Topuz, do you want to
wrap up now?
Close the session?
Of course, my pleasure. Thank you everybody for your contribution, especially our speakers, Dr. Perry, Dr. Acaroglu, and our panelists, Dr. Tushman and Dr. Kahraman. Thank you very much for your contribution to this meeting. Hopefully it was an enlightening meeting for everybody, and we look forward to seeing you again in our next collaboration between Cedars Sinai and Memorial Hospitals Group. I would like to thank everybody who took part in organizing this meeting, and thank you all for joining us, our participants, and hope to see you all in the next meeting.
Thank you.
Thank you.
Goodbye.
Thank
Goodbye.
you all.